Good evening, friends. Welcome to this Tuesday evening academic session from Yashoda Group of Hospitals. We try to bring some current updates, current concerns, current medical debates or controversies to you. And to bring that, we try to bring the national and expert panelists onto the board. And today, we are proud to have Dr. Aparna Mukherjee on board. Welcome you, Dr. Aparna Mukherjee, on board. She has been a MD pediatrics, and followed by she happens to do her PhD in philosophy. So she was doing a philosophy from All India Institute of Medical Science, followed by she is now E-category scientist in ICMR. And she has been working along this pandemic and with different epidemiological studies in the current centuries or so. And we have Dr. Monalisa Sahu, who has been our ID specialist and been on the front line in the part when it comes to the both any infectious etiology related topics, both viral, bacterial, or fungal. So Dr. Monalisa Sahu is our infectious disease specialist, and he has been graduated and doing her DM and post-graduation from All India Institute of Medical Science, and she has been an infectious disease specialist from Yashoda Group of Hospital. I welcome Dr. Monalisa Sahu on board. So, friends, for the last 3 weeks or so, we have been hearing about a new terminology related to a monkeypox. So, this virus has been known to us from 1953 onwards, which was found to a group of monkeys in an area, and followed by in 1970, where it was actually found to have a human transmission. And after that, this virus has been commonly an pandemic, endemic in one of those Western and Central African zones, and seems to have some kind of transmission here and there with the travelers, or when any animal trafficking happening to some of the other Western world countries. But in the last 3-4 weeks, the same virus or the same kind of clinical syndrome has been found across many countries which were not endemic, and there could not be any travel or any link which could be tracked back to this endemic countries. And most of the countries like United Kingdom and Portugal, Canada, and United States of America, and many Western countries have found to have this monkeypox virus. And this has been clinically and laboratory wise has been confirmed. And this created a lot of curiosity. I will say not the apprehension, but a curiosity among many clinicians that in the last 2.5 years, we have gone through one of the worst devastating pandemic, the unprecedented pandemic, which all the medical fraternity and humanity in this universe has faced. And after that, again, hearing about another virus which has been seen here and there is being a little concerned to the medical fraternity. So we have been seeing this kind of viral emergence or re-emergence, both in the form of Nipah virus, and recently Zika virus, Ebola virus, and West Nile virus, and so many in the recent times. So to bring this topic, I will just initially request Dr. Monalisa Sahu to just brush through this topic, and followed by Dr. Aparna Mukherjee will take our questions, and also I will request all the audience, all the participants to post their questions on the question box so that Dr. Aparna can discuss those. Over to you, Dr. Manas.
Thank you, Dr. Venkat. So today we will be discussing an important and interesting topic that is concerning everyone, the re-emerging viruses, along with more importance to the monkeypox. There is a subtle difference between the emerging infectious diseases and the re-emerging infectious diseases. Emerging infectious diseases are the ones which are caused due to the newer viruses or the infectious agents whose incidence has increased over the past 2 decades or threatens to increase over in the near future. This is the definition according to the US National Academy of Science. And certain diseases which fall into this category include the HIV/AIDS, which came in 1983, the hantavirus, the new strain of cholera, the avian influenza, the Nipah, and so on. The re-emerging infectious diseases are the ones in which the infectious diseases are due to the reappearing or a previously characterized infectious agent, and its incidence has been increasing or it threatens to increase in the near future. There have been several outbreaks of these re-emerging infections in India, as you can see in this review article published in 2019. And there have been outbreaks of, like you can see, the CCHF in Rajasthan in 2011, the Zika virus in 2017 in Gujarat and in Madhya Pradesh, and the Nipah virus outbreak in Kerala Kozhikode district in 2018, to name a few. There have been several infectious disease outbreaks, and the viral organisms have been contributing to the majority of them, about 71% of them, and about 29% are due to the non-viral pathogens. The major viral diseases include the exanthematous fevers like the chicken pox, the measles, and the viral hepatitis, the enteritis causing viruses like the rotavirus and the norovirus, and the hemorrhagic fever causing viruses like the dengue, to name a few. And the CCHF, Castor forest disease, and the Zika have been also been reported in our country in certain regions. This is the timeline of the various viruses that have caused the outbreak in the countries over the last 20 years, including the SARS outbreak in 2004, the Japanese encephalitis in 2005, the dengue outbreak in Delhi in 2006, the chikungunya in the same time, and swine flu in 2014, Zika outbreak in Rajasthan and Madhya Pradesh during 2017, Nipah in Kozhikode, Kerala in 2018, and the SARS-CoV-2, which is 2019 to onwards. There have been several mechanisms by which these zoonotic infections get transmitted to the humans. Mostly they are the vector-borne, including the Japanese encephalitis, dengue, Zika, and the chikungunya by the various species of the mosquitoes. They can be airborne like the SARS-CoV-2. They can be acquired from the pigs like the swine flu virus, and also from the bats like the SARS and the Nipah. Coming to, we shall be dealing about the other viruses which have caused outbreaks and in the world in the last few years. Coming to the Ebola, which caused the outbreak in Africa in 2014. It is mainly transmitted by the bats, and the other primates are the accidental hosts, and humans are also the accidental hosts. And when they acquire the disease, the secondary transmission occurs between the human beings. The initial symptoms include vague clinical symptoms like weakness, muscle pain, headache, and the serious complications include the impairment of the various organs like the kidney and the liver, and the severe bleeding and septic shock, which can lead to mortality in quite a significant number of them. The Zika virus is another important virus which caused outbreak in the Brazil in about 2016, and also there were outbreaks in India in the months in 2017 and 18 in Madhya Pradesh and Rajasthan and Gujarat. It occurs mainly in the sylvatic cycle, but due to the urbanization, it may get into the human, the human beings may acquire the disease, and the secondary cycle may occur, urban cycle may occur, and it is also transmitted by sexual intercourse, blood transfusion, and perinatal transmission. So there have been changes in the clinical manifestations of the disease. Like initially it was in the year like 2007, it was presented like mild fever with rash, later on like conjunctivitis and arthralgia. But in this outbreak, it was mainly presented as a congenital syndrome of Zika, which presented with microcephaly and various other problems in the kids and the neonates. Coming to the West Nile fever, this is also like maintains mostly in the mosquito-bird cycle, that is involving the birds and the mosquitoes, but it may accidentally get into the other non-primates, including the horses, and it may also get infect the human beings. It is usually asymptomatic, but 25% of those who get bitten by the infected mosquito may develop symptoms, and they may be non-specific like headache, generalized weakness, fever, myalgia. Neuroinvasive disease can occur in very few of them, like 1 in 150 to 200 may get a neuroinvasive disease, which ranges from West Nile encephalitis to meningitis and even other serious complications. There has been a case of reported of West Nile fever death in Kerala on this Sunday. So there is like more alert in the Kerala. So this is also could be important one. The other one is the Nipah virus, which there was an outbreak in Kerala in 2018, and about 19 cases were reported, of which there were 17 deaths. And it was acquired mostly in the regions where the Pteropus bats are mostly present. And previously also there had been a few cases, like in 2001, 66 cases of this Nipah virus were reported from Siliguri, and later on fewer cases from West Bengal in 2007 were also reported. So the Nipah has got a higher mortality rate as compared to the other viral infections. This is the chart showing the case fatality ratio of the various infectious diseases. Nipah has got the highest mortality rate, about 40 to 75% of them, and the SARS has also got like 14 to 15% of mortality ratio. The SARS-CoV-2 has got a lower mortality ratio, about 2.76. And in case of Zika and chikungunya, deaths have not been reported. Now coming to the which is the talk of the most of the world now, the monkeypox, and which has been like this monkeypox has been there since several decades, but it was endemic in the African countries. Now that it has been reported in the non-endemic areas, it has caused a greater concern. According to the WHO site, which was updated on the 26th of May, about 23 countries across the globe have acquired the disease, and about 4 regions of the world have got the disease, accounting to about 257 cases. Even it is there in the endemic countries, the number of cases has been increasing. The highest number of cases being reported from the Democratic Republic of Congo of about 1,284 cases, and also from Nigeria and Cameroon. There is a wide host range for the disease, and mostly it is the reservoirs are the rodents. The primary hosts are the rodents, and the incidental hosts include the non-human primates, including the other squirrels, the rats. So like the human beings can acquire the disease from several modes of transmission, including by the points of entry can be through the broken skin. The respiratory tract can now act as the organ of entry into the body, as well as exposure to the mucous membranes, including the eyes, nose, and mouth. Animal to human transmission can occur by the bite or scratch of the infected animals, consumption of the bush meat, like eating the meat of the infected animals, direct contact with the fluid from the lesion material of the infected animals, or indirect contact with the lesion material. Human to human contact has also been reported in this outbreak, and it is via the respiratory droplets with the close face-to-face contact, direct contact with the lesion material, even indirect contact with the contaminated clothes or linen, inoculation of the infected material, and transplacental infection, that is congenital monkeypox, has also been reported as a mode of transmission. The pathogenesis includes after the entry of the organism into the body, which can be through all of the routes that have been described. It enters the reticuloendothelial system, causing the prodrome of symptoms, the fever, and the lymphadenopathy. Lymphadenopathy occurs as one of the most important symptoms in this monkeypox, which is not seen in the other pox virus infections. The skin lesions also are, the duration of lasting is also longer. The evolution of the various skin lesions occurs over a period of time to 2 to 4 weeks, and it starts as a small vesicle, which progresses into a small pustule, further into umbilicated pustule, ulcerated lesion, and crusting occurs later, and the scab forms, which falls off. And this whole thing, it takes a period of about 2 to 4 weeks. The clinical features include a prodromal phase, which includes fever, lymphadenopathy, which is one of the important features, intense headache, myalgia, back pain. They can occur as in the other viral illnesses. The skin involvement is quite common in them, and the face and extremities are involved. The palms and soles are involved in about 75% of them, and oral mucosa, the genitalia, as well as the conjunctiva can also be involved. Severe complications can occur in a few of them. Usually the illnesses are self-limiting, but severe complications can occur in the individuals with underlying immunodeficiency or chronic disorders. Severity is more likely in the case of children. And the secondary infections can also occur like with other viral infections like pneumonia, sepsis, and encephalitis. Occurrence of corneal lesions can lead to loss of vision as well. There are certain differences between the smallpox and the monkeypox. The incubation period is a variable from 5 to 21 days in case of monkeypox, whereas it is from 7 to 19 days in case of smallpox. The secondary attack rate is lesser in case of monkeypox, the number of cases acquiring the disease after exposure to an affected individual. It is about 30 to 80% in case of smallpox, but it is about only 8 to 9% in case of monkeypox. The clinical features, the lymphadenopathy is one of the significant features of monkeypox, and the mortality is also lesser in case of about 11% in monkeypox as compared to 30% up to 30% in smallpox. Also, the certain features are different between the chickenpox and monkeypox, the lymphadenopathy is more significant in monkeypox, and the lesions are in the different stages of evolution in the case of chickenpox, but they are all in the same phase in the case of monkeypox. And the progression of rash is also slower in case of monkeypox. As you can see in the images, the distribution of the rash in case of smallpox is more on the face and the extremities, whereas it is evenly distributed in the case of chickenpox. This is the diagnostic criteria for smallpox, which includes epidemiological criteria as well as presence of the other systemic features like fever more than 101, along with prostration, headache, vomiting, severe clinical abdominal pain, classic smallpox lesions, and the lesions in the same stage of development in one of the parts of the body, like the face or the arms. There are certain salient features of this outbreak of monkeypox, which includes the identification of the cases that have been identified. They do not have a direct travel link to the endemic areas. This is highly unusual because the previous outbreaks that have been there, they could be tracked, traced to the either to the exposure to the international travel or to the exposure with the animals that had been brought. But in this outbreak, the cases are not able to directly trace the origin of the cases, like how they acquired it. And it also, this current outbreak, the human-to-human transmission is more seen, and more so in the individuals who are in the close contact of those with the symptomatic individuals. And more cases are also being seen in the population of men having sex with men who are seeking the primary care in the healthcare clinics. And most of the cases of this outbreak are of the West African clade. There are 2 clades, of which the cases in this outbreak are of the West African clade. And the genome isolate of the individual from Portugal is closely resembles that of the individual from Nigeria. The outbreak isolate from that caused the outbreak in Nigeria and Singapore in 2018 and 19. Coming to the position of India, no case of the monkeypox has been reported from India so far, and the Union Health Minister of India has directed the NCDC and the ICMR to keep a close watch on it. Symptomatic travelers should be isolated at the various points of entry, like the airports, seaports, and the land borders. And the samples need to be sent to the BSL-4 facility that is there in the INIV Pune. Coming to the management of the cases, it includes supportive care, antivirals like the tecovirimat and the brincidofovir and sitofovir, and the immunoglobulins and the vaccine, the vaccinia immunoglobulin. Coming to the antiviral agents available, the tecovirimat is the antiviral which has been approved by the FDA in 2018 for the management of the smallpox, and it inhibits the P37 region of the virus, which is the most one of the most conserved regions of the virus, orthopox virus, and it prevents the aggression of the enveloped variants, which is required for its pathogenesis. Thus, it inhibits the action of the virus, orthopox viruses, and it has been approved for the smallpox, and it can be useful in the case of monkeypox as well. The other agents that are available and have got the US FDA approval include the brincidofovir, cidofovir, ribavirin, and edifovir. Coming to the prevention and control, the prevention of monkeypox includes strategies including immunization, post-exposure prophylaxis, and infection control. Immunization, there have been several vaccines over the last centuries. The earliest vaccine was the one which was a smallpox vaccine as early as in 1805 in Italy. The next vaccine was the live virus smallpox vaccine, which was manufacturing was stopped in about 1980s, and it was replaced by the live virus vaccine ACAM 2000. And the latest vaccine, the Vaccinia Ankara MVA BN virus vaccine, which has the latest vaccine, and it has been approved by the US FDA for the vaccination. And it is also like excellent activity, and even it can be given in the immunodeficient individuals. Coming to the indication of these post-exposure prophylaxis, it is most effective when given before the exposure, but the CDC recommends that it should be given post-exposure to the individual, to a positive individual, and it should be given within 4 days of the exposure to prevent the onset of the disease. If it is given between 4 to 14 days after the exposure, it may cause a lesser severity of the disease, and revaccination may be recommended in individuals who have not received the smallpox vaccine in the last 3 years. Coming whether there is a vaccine risk versus the monkeypox disease, the risk with the vaccine is very less, as low as like 1 in every million people who get vaccinated might get the smallpox disease due to the vaccine itself. But the monkeypox, the mortality rate is far higher, about to the tune of 1 to 10% in the infected individuals. Coming to the post-exposure prophylaxis, the vaccine and the immunoglobulin are the two modalities. The immunoglobulin is the Vaccinia immunoglobulin, and much data is not available on it. It is an investigational agent and does not have much proven efficacy in preventing the smallpox complications. It is indicated in those individuals who are severely immunodeficient, severe T-cell immunodeficiency is there, and for prophylactic use in the individuals in whom the monkeypox vaccine is contraindicated. Coming to the dose of the immunoglobulin, it is about 6,000 units per kg, and the repeat dose may be required in case of severe diseases and depending upon the response of the individual. Coming to the infection control, it should be done at the level of the hospital where the patients are present, in the home where there is care of the affected patients has been taken, the duration of isolation, monitoring of the exposed person, and ring vaccination. These are the several strategies that need to be taken care of in the infection control. In the hospital, standard contact and droplet precautions need to be observed. Personal protective equipment should be used, and isolation of the patient should be done if possible in a negative pressure room, or if not available, then the other patients should not be exposed to him. The duration of isolation varies, and it should be up to at least until all the lesions have resolved and a fresh layer of skin has been formed. Following the discontinuation of the isolation prevention precautions, even these individuals should not be allowed to come in close contact with the immunocompromised individuals until all the crushes have fallen off. The monitoring of the exposed person should be up to 21 days after the last exposure, and the monitoring should be for the symptoms like the fever, chills, lymphadenopathy, new onset, and skin rash. And if in case the health professionals are exposed, they need not be given excluded from work and should be observed for a period of about 21 days. Ring vaccination is one of the strategies which was undertaken at the time of smallpox to get rid of it. In this, it is like the vaccine individuals who come in contact of confirmed cases of smallpox are first vaccinated, followed by those who come in contact of those contacts, and finally everyone who has been exposed to the patient receives the vaccine. So this is the ring vaccination strategy which was earlier used for smallpox, and this can also be helpful in the case of monkeypox. So should we be worried about this monkeypox? Because there is definitely not many effective drugs against it. The vaccine production and availability of vaccines is also limited, and use of personal protective equipment should be given high value so that we can prevent ourselves. And also India has got a large vulnerable population, so should we be worried? With these questions, I end the talk so that we can have the discussion.
Thank you, Dr. Monalisa, for that update and bringing those information. I will request Dr. Aparna Mukherjee to unmute herself, and ma'am, for the last 3-4 weeks, there was a lot of concerns and curiosity among the clinicians to know about this new re-emergence virus, monkeypox. The reason for that has already been highlighted is there have been more than 20 countries, more precisely 23 to 24 countries, this virus, this patient has been identified with the clinical symptoms and has been laboratory-wise confirmed. But we could not track the link with the endemic countries. And those all countries where we are seeing these viruses are non-endemic countries. And earlier to this also, from 1972 till even 2019, we have seen these cases in endemic countries, on and off in non-endemic countries, with a track of travel or with a track of some animal tracking. But currently, we are not able to track any links to the endemic country. So what does this actually gives us a clue? Is this give us a clue about a missing link of transmission? What is your take, Dr. Aparna?
Well, first of all, I would like to say that Dr. Monalisa gave a very comprehensive view of our emerging and re-emerging infections. And secondly, I would say my PhD was on pediatric infectious disease, particularly tuberculosis. In terms of emerging and re-emerging infectious disease, a vast majority of them are zoonotic diseases. And some of them are vector-borne, some via direct transmission. So as you were saying, that there is always this, there needs to be investigation for these links of transmission. For monkeypox, like when it was earlier found in non-endemic countries, like there was an outbreak in 2003 in United States where they could trace it back to rodents which were brought in from Africa. This time around, they are not being able to trace it particularly, which is a bit troublesome. But where did the index case come from? That is what is not being able to, I mean, how did the index case get the infection? But after that, the transmission, whatever transmission has occurred in around 300 odd cases, mostly they are between individuals who like MSM individuals and for very close contact. So it might be that we are missing a link for the first case where, because the genetic sequencing have shown that these cases are very similar to something which came from Nigeria earlier. So probably we are missing some kind of a link there. And of course, like you said, that with more of travel, with more of urbanization, we are kind of blurring the line between wild life and domesticated life, human, and that's why we're getting these cross-species transmissions so high. But as of now, I would like to say that monkeypox, as what we are getting, we have to be very alert and we have to be aware of what is happening. But there are certain advantages, if you could consider it as advantage in this particular viral disease as compared to what we saw, the havoc that we saw in case of SARS-CoV-2. Because here you need a very close contact, a face-to-face contact, or not necessarily a sexual contact, but a very close contact, because it's primarily, though it can spread by respiratory means, but it primarily spreads by the lesions, the contact of the lesions or contact of the, whatever, linen, clothes, etc. And so that is something good that we would expect, that it is not going to have a widespread transmission. And secondly, smallpox, definitely smallpox vaccination, the population that has been vaccinated, say for our country up to 80s, smallpox vaccination was universal. So those who have already been vaccinated, there is almost 85% cross-protective efficacy for smallpox vaccination. So that will actually protect a large chunk of the population. So it is the younger population who are susceptible.
Yeah, Dr. Aparna, will come to vaccination. Now that means, you mean to say that there was ongoing some transmission where we are missing link from 2019 onwards from this endemic countries to these non-endemic countries on some place, so slower pace, or somewhere we are missing link, and now we are seeing here and there the cases of in non-endemic countries. So there has been also a concern related to men having sex with men, attending a venerology clinic or STD clinic, having more propensity to detect this monkeypox. The number of cases were detected more in that particular category of population. So is that being a concern? Is this being a mode of transmission, or is that just like a coincidence that these are all patients who just come to the clinic, because it also affects the genitalia, it also affects the mucous membrane? Is that being a concern?
It's more like the close contact, the very close contact, which is the cause for transmission, rather than it might be sexually transmitted as well, but that is not the main, that probably is not the main mode of transmission. It is more of the face-to-face contact, the very close contact during the activities that is causing the transmission. And since for some reason it had started in the MSM group, and that's why it's like spreading from there within that group. But there's no reason to believe that it is particularly only sexually transmitted.
So it may not be just limited to them. It can spread across anyone who can come in direct contact with this mode of transmissions, whatever it is. So the countries at risk, we now have seen, we know the Central and West Africa being the common endemic countries. And also now we have seen another 23 countries which are not endemic, but has been having detected to have this virus being found in those countries. And now, which countries do you think are at risk? Is the countries next to it, or with current travel pattern, any country can be at risk?
With current travel pattern, you can go from one point of one end of the earth to the other end in some hours, right? So none of the countries exempt from being at risk. So, but right now we are getting the European countries, Canada, Australia, these are the countries that are being affected. But as the international travel is so prevalent nowadays, so therefore we are keeping a watch so that anybody who is traveling from these affected countries they have visited within the last 21 days, considering that the incubation period will be 5 to 21 days, are being watched for symptoms. Because again, thankfully, as of now, the asymptomatic infections have not been found with this virus. It is only it does cause symptoms, and it is the symptomatic period which is infectious. So that is why the symptoms are being monitored, and there is provision if there is, according to the case surveillance, if anybody meets that definition, then the samples can be sent to NIB, which is a BSL-4 facility, and where it can be tested for monkeypox.
So no country can be immune. All countries need to keep a vigilant watch of this transmission. So what is the risk of this virus, monkeypox, which can cause a pandemic? What is the risk this virus carries?
As I said, it is unlikely that it is going to cause a pandemic. Like what we saw in SARS-CoV-2 was the very great ease of transmission from human to human. But here, as we said, that there are many factors which can put a break to that transmission. You need very close contact. There is no asymptomatic carrier state. The person is infectious only during the symptomatic phase. So it is easy to isolate that person, and for the caretakers to be vigilant that they don't get infected. Then a large population is already vaccinated with smallpox vaccine. So taking into consideration all these factors, it is unlikely that it will become a pandemic of the proportion that we just had.
So you mean to say that if you are vigilant, and the containment of this kind of virus is far more easy than what we have seen with a droplet-borne or aid-borne viruses like SARS-CoV or so. So
yeah,
the spread can be.
We'll have to be aware, and we'll have to be vigilant.
So we need to restrict this virus to the area with all this information and all. Ma'am, you spoke repeatedly about vaccination. I do understand probably many of us before 1980s, this immunization has been stopped. And I believe the human population who born before 1980s may have a vaccination. So after that, if you look at that, there are around 43 years. This last 43 years population from 1980s are not vaccinated. And was this vaccination across the globe at that time, or India was when vaccinating with smallpox? Across the globe, this was vaccinated till 1980. And in 1980, the vaccine, the smallpox was been declared as eradicated. So these last 43 years, this population has not been vaccinated. So there is a big chunk of a healthy younger population who have not been vaccinated. So what is your take on this? Those who are born before 80, probably we have some immunity. And those vaccines you still believe are effective right now after 43 years too?
Should be.
And what about this 43 years current, they should get vaccinated in the area of propensity, or that may be a concern in the future if this virus spreads?
Like as we are repeatedly discussing, it is unlikely that it's going to be a pandemic proportion spread. So vaccinating the whole of our population below 43 years of age, that doesn't seem to be a very prudent idea. But we do have vaccine, as Dr. Monalisa told you, but then they are not readily available because there is no stockpiling of those vaccines because it was not needed as of now. So if the case arises that there are clusters being seen of this particular virus, then we could think of vaccinating those people, and then the ring vaccination can be done. But as of now, vaccinating the whole population doesn't seem very prudent.
Okay. And there is also concept of post-exposure prophylaxis with the vaccine and also antivirals. So you mean to say if we get a cluster somewhere in India or any, particularly in any other countries, they may get this antivirals or these vaccines in the post-exposure period can be a phenomenon in the future if at all this virus stays with us?
Can be a strategy if required. As of now, none of the countries are actually implementing that strategy.
Ma'am, Dr. Monalisa elaborated on the role of immunoglobulins. As we know, many viruses, including rabies, in the tetanus, we nowadays are talking about immunoglobulins giving in this patient. So, role of immunoglobulins in monkeypox.
As she already described, that it is not really well known. I mean, as in all viral cases, we might try, but then we really don't have evidence to say that it will halt the progress of the disease or will really cause any improvement. And again, the thing to remember is that monkeypox is a self-limiting disorder. So if you take what is important is the symptomatic care would be much more important. The lesions so that they don't get infected, eyes are affected. So give vitamin A supplementation, take care so that there is no scarring. That will be more important. So that is the message that we should be sending to all clinicians rather than, immunoglobulins, which may or may not work. Or may not be available.
So what we understand from your views, ma'am, right now monkeypox may be limited to those non-endemic pockets where there are some clusters of cases. If we take a vigilant care of this, probably we still have probably a chance that this will be contained in those zones. But the core topic of today, why we brought today's discussion, is not just about monkeypox. This is to understand from you that we have been seeing on and off emergence of new viruses like here and there. And then we also see re-emergence of viruses like what we have seen SARS-CoV-2, which created a havoc in the last couple of years or so. And then we saw Nipah virus being pocketsly, clusterly seen with Kazikot taking 20 lives. And we have seen Zika virus in the last decade or so, and Ebola in the same African endemicity. So what we wanted to understand is this kind of what the new emergence of viruses from genetic, as you said, the emergence and re-emergence more commonly linked with the genetic wildlife. So are we really creating a culprits invading into the what you say, the animal lives or wilder lives, or is it like we are a part of this whole phenomenon of cycles of infections?
To some extent, these cycles can be, expected, but then definitely we are invading into the territories where we shouldn't. As I said, the line between the wildlife, domesticated life, forests and agriculture, it's blurring. So obviously the natural habitats are mixing. And so there is a chance, more chance of viruses jumping from one species to another. Like you mentioned Nipah. So Nipah was in, there has been extensive epidemiological investigation as to how it spread. And so in Malaysia, we saw that there was increased in pig farming, and they had they also planted fruit trees along those pig farms where fruit bats migrated to that, and that's how it spread. So the more you penetrate into the areas where you have these wild reservoirs, be it rodent, be it bats, so and the more affected we get.
Ma'am, how do you look forward in the future? See, is it been a normal phenomenon we need to face, prepare ourselves, or is there any way to go forward? You have been into both epidemiology and philosophy. How do you actually guide us to the clinicians and the humanity in the world?
Oh, right. So this is, this is the subtopic of One Health that we are listening to now, that we take care of our animal health, we take care of the environmental health, and we take care of the human health in the process. So we say with the increased urbanization and with increased agriculture, with the intermingling, we can expect that there will be emergence of more viruses, because most of them are viral diseases and most of them are zoonotic. So we can expect this. So one is to spread the awareness so that as much as possible, we preserve the natural reservoirs, the wild animal transport, illegal or whatever, and the wet markets, they're all regulated. So that is important. And secondly, obviously, the vigilance, the surveillance is important, so that we can pick up any early sign that there is a cluster of some unusual infectious disease, and that can be investigated.
Ma'am, you brought a very right point. When we see a cluster of cases where we do not understand, the similar thing, type of thing happened in Nipah with Kajikot, when one of our friend or a colleague who was an intensivist there, along with his neuro colleague, has initially suspected this. So that's a very, very tricky or a very important component of actually picking up if any kind of this new syndromic or a cluster appears. So how, from an epidemiological perspective, what will be your message to the clinicians? How do we actually make this alert to either a virology unit or some way to take help?
Right. So IDSP does have that channel that whether right now it doesn't do these active surveillance, but then if there is a local outbreak and if you think that there is something unusual going on, you're suspecting, you can always report to IDSP. And after this pandemic, there is a lot of work going on from all the medical research bodies in order to strengthen the pandemic preparedness in terms of like awareness amongst clinicians, their capacity building as to when to suspect and when to report and those kinds of things.
No, ma'am, I'm trying to ask you, how do actually clinicians suspect a possibility of some new virus emerged or new pandemic we are looking? So now that we know a monkeypox with the clinical features, if I suspect somebody, I can report. But for the first time, when we don't know, when there is a case series emerging, how do we suspect? Is that being a typical syndrome which is not fitting? Then we keep on suspecting. How do we suspect? See, many times we don't get into a final conclusion of diagnosis. In many viral diseases, we do a dengue or we do chikungunya, that's it. The rest of the viral syndromes are not been evaluated in tropical viral syndromes. And Hanta and all also been never been evaluated. In those contexts, I'm just trying to know from the clinical perspective, how do we suspect this kind of new emergence of any viral diseases?
Right. So the new viral disease, they're not going to have any set some, number of symptoms that you will be able to suspect. But definitely once you are dealing with a whatever fever, rash, encephalitis, anything, and you will have your differential diagnosis. So this will be an exclusion, right? When you cannot fit into the usual diagnosis that you have, then you think of unusual diagnosis, right? So if there is possibility of getting this person tested for those unusual causes, you get them tested. If not, take cognizance of that. And if you are getting number of cases, number of people who are showing that similar type of presentation, which you cannot fit into the known diagnosis, then you can think of that there is something going on. Then you can take help for diagnosis, for cultures, viral cultures, and etc. etc.
So how do we report, ma'am? Just we wanted to know from the clinician point of view, how do we report that? How do we take help?
How do we take help? As I said, that if you suspect a cluster, you can report to IDSP saying that this is what you have noted, what are which history, which region. Then they will send a surveillance team to see what kind of outbreak, what symptoms, and investigate epidemiologically to see whether it is really matching into something new or re-emerging, or it is just you're missing the diagnosis.
Right now, both WHO and ICMR both has given some vigilant signs at this point of time, even for the monkeypox, to keep a watch. So suppose any of our clinician come across the chickenpox has been very commonly seen on and off in very many seasons. In the similar way, if they come across some suspected case of any smallpox-like lesion or a monkeypox-like lesion, how do they actually again go about? What is the ICMR or right now current government of India stand, right?
Right now, the this thing is you'll have to contact NIB because they are testing. They have a testing facility, and you'll have to follow they have actually released a guideline as to what are the samples that you can take. That is the lesion fluid or the lesion scab. Along with that, nasopharyngeal, oropharyngeal swab, though that is like more for research purpose and to see that whether that can also detect, and as well as blood. And then you have that triple packaging and labeling as of any biohazard substance that you are transporting, and it has to be transported to NIB.
Okay. So, Dr. Monalisa, you have been in the forefront of this last pandemic, and now you have been also yesterday, you said the day before yesterday on Sunday, there is a report of West Nile. In the last decade or so, we have seen many viruses. What is your take right now in Indian context, in your city context, with the current travel? You must be seeing many patients who are traveling across the borders, even from the West and Central Africa to your hospital, to your city. So how do you see that?
Like the population of India is very susceptible, vulnerable to all the infections like the rest of the world. And the international travel has caused the world to be a smaller place. So any of the diseases which are endemic in the other parts of the world can definitely be imported to our place, and our people can get infected with that. So we should be aware of the various signs and symptoms of these infections, and be aware of the world epidemiology, like any outbreaks anywhere in the world. We should be aware of that, so that if in case we come across such infections, we can detect them early with the various signs and symptoms and report it.
So again, tracking, tracing, and reporting, isolating, and examining, probably the same formula which we used in the early part of COVID. COVID has done one good side of it. It alerted a lot of clinicians in different ways, how epidemiological study done, investigations were done. What is your take-home message, Dr. Aparna, to the audience for today's webinar?
Right, that yes, as you said, that COVID, of all the bad things that we encountered, there has been some pros in the sense that pandemic preparedness is in everybody's mind now, and we are more aware of such conditions. So right now, for any new virus that is emerging or whatever we have now that is monkeypox, our responsibility would be to have a heightened vigilance, be aware of what is happening, so that what kind of case you might have, and treat them according to whatever available modalities are there.
Any take-home messages from Dr. Monalisa?
Like I said, we should be aware of the world epidemiology of the diseases and the upcoming diseases, and the previous infections, they can always be re-emerging. So we should be more vigilant and be aware of the various infections and their manifestations, so that early diagnosis can help.
So right now, both Dr. Aparna and Dr. Monalisa emphasizing that the way the transmission rate of monkeypox may limited to current endemic countries and non-endemic countries where it has been found, because the transmission is much lower than what we see with airborne or a droplet borne, and it can be contained with vigilant care. But in the meantime, none of the countries can be careless or can be considered immune. So all of us need to be vigilant and probably watchful whenever there is any epidemiological evidences of this cluster of infections emerging, re-emerging. We as a clinicians or we as a healthcare professionals need to be very, very cautioned and report and trace and probably send the sample on suspecting. Not just about monkeypox, Dr. Aparna has emphasized, if you get a cluster where you are not able to fit any clinical syndromes of your zone and you find them to be little atypical and there is a cluster of cases coming one after the other, keep yourself on high vigilant, try to probably escalate to the NIV Pune or try to take the help so that we can probably get in more clearance that what exactly we are dealing with. And with this, I thank Dr. Aparna Mukherjee to spare her valuable time and be with us. It's a proud moment for us, ma'am, to be a part of the webinar with you. And thank you, Dr. Monalisa Sahu, in bringing this update and enlightening all of us on this emerging and re-emerging viral infection. I thank all the participants for actually joining us and making this webinar interesting. Thank you. Thank you all. I conclude the session. Thank you.
Thank you. Thank you for inviting me.